Dr. Sheetal Madla.
Should I start?
Yeah, please.
Good evening, everyone. Topic for my presentation is modifying sclerocorneal tunnel construction in manual small incision cataract surgery, crescent versus keratome. Introduction. The progress in cataract surgery aims to discover surgical techniques capable of delivering accurate and predictable outcomes. Manual small incision cataract surgery is regarded as a safe, straightforward, reliable and economically viable method for cataract extraction. The lower expenses associated with instrumentations make manual SICS particularly advantageous. A well-constructed scleral tunnel promotes self-sealing, enhances wound stability, consequently reducing surgically induced astigmatism. Proper tunnel construction is necessary, for which availability of instrumentation is necessary, which is sometimes difficult in resource-limited peripheral institutions. So the aims and objectives are to study the difference of surgically induced astigmatism between sclerocorneal tunnels made with crescent versus keratome, to see for the complications associated with use of keratome for tunnel construction, and to validate the use of keratome for tunnel construction in the resource limited institution. Materials and methods. This study was carried out at a tertiary care hospital from June to November in 2023. In this investigation, 60 patients were selected and they were categorized into two groups. First group consisted of 30 individuals who underwent the SICS surgery with sclerocorneal tunnel construction using crescent, and the second group consisted of 30 patients who underwent SICS surgery with sclerocorneal tunnel construction using keratome. Before beginning the study, all study participants were provided with written and informed consent. Inclusion criteria: patients experiencing vision impairment due to cataracts of any severity. Exclusion criteria: patients with concurrent visual conditions such as glaucoma or corneal abnormalities which could impact post-surgical visual results, and the patients with traumatic and subluxated cataract. Pre-operative assessments were done, which included visual acuity, Snellen's visual acuity chart, slit lamp examination for cataract grading, intraocular tension, fundus examination, pre-op keratometric reading, A scan, B scan in hazy media, and post-operative keratometry and refraction were done 1 month post-surgery. These are the images showing tunnel construction using 2.8 mm keratome. Result. The mean keratometric readings in the first group before surgery were K1 43.97 and K2 44.56, while after surgery they were K1 44.37 and K2 was found to be 44.95. In the second group, the pre-op mean keratometric readings were K1 44.12 and K2 was found to be 44.76, which changed to K1 44.55 and K2 45.12 post-operatively. The mean astigmatism at 1 month post-op was found to be 0.7 plus minus 0.3 in the first group and 0.9 plus minus 0.4 in the second group. There was no statistically significant difference in both of the groups. This is the table showing surgically induced astigmatism in both of the groups. This is the table showing mean surgically induced astigmatism in both groups. It was found to be 0.9 in the first group and 0.7 in the second group, which was found to be statistically insignificant. Discussion. This was the comparative study in which we examined the surgically induced astigmatism in both of the groups. Till date, there has been no previous research on the comparison of effectiveness of blades, including crescent and keratome in cataract surgery. Mean astigmatism in both of the groups was found to be statistically insignificant. Thus concluding, sclerocorneal tunnel with crescent and keratome produces similar astigmatic outcome, and there were no complications experienced by the surgeon during tunnel construction by keratome. Thus this study suggests the use of keratome for tunnel construction resource limited institution, provided surgeries are performed by experienced hands. Thank you.
Age criteria?
Yes, sir.
Age criteria was taken. Any inclusion on the age, exclusion on the?
No, sir.
So you said that it is basically resource limited. So how does it make the difference? The crescent is around 30 rupees or the keratome is also 30 rupees?
But we are doing surgery in only one instrument. Means incision was also taken with the keratome only, and tunnel was made with the keratome, and side port was also done with the keratomy.
Right. Thank you.
Thank you, sir.
So next is Dr. Kumar, doctor, and co-author Dr. Shivani Patnaik.
So he's not able to attend this because of a family issue. Can I present? Because
You are the co-author.
yes.
You can.
So I also have a talk in this. So in case that's a conflict, then you can choose not to judge
In-
this session.
In this session.
I'm primarily author in one.
No, it is not enough.
So I'll present my case now.
Yeah. So let me call accordingly. Dr. Shivani Patnaik. Next is the third hand modified irrigation tip for bimanual.
That is his.
Okay. So yours is
Good evening, everyone. So this is a slightly unconventional paper. It's not a study, it's a technique. So as a PG student, I used to find this extremely daunting, and I was taught needle CCC, cystotome CCC, which was extremely comfortable for me. So for me to break out of that took a really long time, because I found doing all my cases with needle CCC quite comfortable. But the day when I had to use a microrhexis forceps for the first time, it took a lot of effort from my side, and eventually it ran away. So Professor Howard Gimble and Professor Thomas Newhan introduced this concept for us, which is a very critical surgical step in cataract surgery that involves creating a smooth circular opening in the anterior lens capsule. Now, CCC is such an important step, so is every step to make phacoemulsification surgery successful. But this is what centers the whole surgery. If the CCC is small, it can lead to a domino effect of one thing going wrong after another and lead to the downfall of your case. So this is a cystotome CCC. I'm using an image-guided technology to guide the CCC dimensions. So this is a 5.5 rhexis that I'm trying to attempt. Now here I have done it at a 170 degree angle because I'm trying to implant a toric IOL. I have gone directly through the main incision. Viscoelastic egress is present but minimal. I still prefer to choose a cystotome over this because I was not confident about my forceps rhexis, and I managed to do it well. So it was still 5.5, so why the need to switch? Now, benefits of cystotome CCC, you can go through a very small incision. It is held close to the tip. There is much greater control is what we feel than a case of rhexis or microrhexis forceps, as opposed to the steel or titanium forceps. Now if you have a shallow chamber, you need a different angulation. If you have a deep chamber, you need a little different angulation of the cystotome, which I can bend according to my need. But I can't do that with the forceps. I'll have to bend the forceps or modulate the way I'm holding it. Benefits of forceps CCC. Now when it comes to hypermature cataracts where the turgidity of the bag is not that great, when it is weak, the bag is weak, when the pressure of the bag is not that great, the posterior CCC creation, extending a small size rhexis after IOL implantation, I had to pull a runaway rhexis using Little's maneuver. This is when forceps CCC comes in play. Now there is a tip to manage the initial tear, which is to not make it very long. If it is around 1.5 millimeter, it is going to extend 2 to 3 millimeters beyond, so keep that in mind. It involves the use of specially designed forceps to pierce and grasp and carefully rotate in a circular motion. It offers better control over the flap, allowing the surgeon to feel when you're pulling. It is a shearing force which is used rather than a tearing force which is used in CCC, so you can easily pull it towards the center if it's suddenly running away. Now, why does it stand out? It offers tactile feedback, allowing us to take a feel of the flap itself rather than trying to push it against the nucleus. Now this is a CCC with the forceps. You can use a corneal rhexis marker as a guide as a beginner and try to center the rhexis around it, make an incision. There will be minimal viscoegress depending on the type of OED you use, also the pressure that we apply on the posterior lip of the incision. Not to enter straight but to enter diagonally, that always helps. And it is important to know that the width of the incision is 2.2, cannot open the instrument completely, that will lead to more viscoegress. Enter slowly, and then if the patient is uncooperative in some cases, better to block initially when you are using the forceps for the first time so that you can get a hang of the instrument first. After that you can go on for topical cases. Even then, if there is an issue, then you can use a secondary instrument to stabilize the eye. Like this. So once the eye is stable, you can grasp and re-grasp at the point of initiation. So always grasp close to the leading point, and that will complete your rhexis. So viscoelastic escape is more with forceps, obviously because using the main incision. Control is more with forceps once you master, but both techniques are very important to use. Transitioning to forceps, you should remember these important points. Visualization in initial cases should be good. Don't choose a small pupil, don't choose a cornea which has opacity. Put adequate viscoelastic, don't feel the need to complete the case with one injection. Come out and re-inject, but not too much. And stain the capsule and use a ring rhexis marker. So start with cystotome because it gives you a good control. Then you move on to forceps because you need another technique in your bag in case you're not, in case the rhexis is running out, it's easy to pull with the forceps. Gradual transition is the key. Chamber dynamics and hand stability, the more you practice, the better it will get. Thank you.
Thank you. Next is Dr. Vinita Yadav. Is she there? Dr. Gogoi Raran. She's not there. Next is Harun Rishi, Dr. Harun Rishi. Dr. Harun Rishi, the topic is USG mandatory prior to surgery in mature cataract.
Good evening to everyone. USG mandatory prior to surgery in mature cataract. Case history: a 60-year-old female presented with headache and severe pain in right eye for 2 days following cataract surgery. On clinical examination, visual acuity in right eye PL negative, left eye visual acuity was 160, eye wall was stony. On digital examination, diffuse corneal edema. On slit lamp examination, right eye was IOP 38 mmHg, fundus, full anterior chamber, hyphema with absent fundal glow. Rest ocular examination was normal. The patient underwent right eye evisceration. During surgery, there was profuse bleeding and uveal tissue was thick, firm and adherent to sclera. Result: the tissue was sent for histopathology, which was suggestive of moderately differentiated adenocarcinoma. USG of other eye was done, which also showed metastasis. Histopathological finding from the multiple tissue bits showed areas of hemorrhage and necrosis, along with uveal tissue inflated by tumor, bilindrol pattern, solid nest, as well as singly lying cells. The individual cells are pleomorphic and hyperchromasia and high nucleocytoplasmic ratio and are forming well-defined glands at places surrounded by desmoplastic stroma. This impression shows suggestive of moderately differentiated adenocarcinoma, possibly metastatic. Conclusion: expulsive hemorrhage during cataract surgery was attributable to choroidal metastasis in adenocarcinoma breast. This case determines the clinical significance of pre-op USG in mature cataract surgery. Detailed history beside ocular complaints is emphasized, as patient had breast lump which she thought was insignificant to tell the doctor. Thank you.
But even otherwise, if it is a mature case, ultrasound is always mandatory.
Sir, he was operated in another hospital. She was referred in our hospital after mature cataract surgery.
Okay.
Then during surgery, profuse bleeding occurred. Then he referred in our hospitals.
So what is the advice for the second eye? You found metastasis there?
Then sir, for radiotherapy and consult to oncologist consultants, radiotherapy and the treatment advised by them.
Sure. Right, Dr. Haran. Thank you. Next is Dr. Sushmita Bhuiya. Dr. Sushmita Bhuiya. Next is Dr. Simran. Co-author Dr. Urmila Rawat and Dr. Shivangi Singh. Overcoming postoperative hurdles, managing challenges after phacoemulsification in uveitic cataract. Are you ready?
Good evening one and all, I am Dr. Simran, junior resident from MGM Navi Mumbai, and I will be sharing with you how we overcame post-operative hurdles in a phacoemulsification in uveitic cataract. Uveitic eyes account for approximately 1.2% of all patients undergoing cataract surgery, and managing cataract in such patients is often challenging due to pre-existing chronic inflammation. Furthermore, the corticosteroids commonly used to control uveitis can inadvertently accelerate cataract formation. Case report. A 50-year-old male presented with gradual painless vision loss in both eyes over 3 years associated with on and off redness. Patient was a diagnosed case of chronic uveitis under treatment and denied any history of trauma, infection, joint pain or systemic illness. Visual acuity in right eye was HMCF, PL positive, PR accurate, and in left eye was finger counting at 3 meters. On examination of both eyes, the conjunctiva was congested, cornea showed fine keratic precipitates, anterior chamber was shallow in the periphery, and annular posterior synecdoche was noted and dense cataract was present. IOP was 10 millimeters of mercury and fundus details were not seen due to cataract. USG-B scan was within normal limits. The patient was planned for right eye phacoemulsification. The synechial adhesions were released through the side ports and pupillary dilatation was achieved through iris hooks. Then the cataract was emulsified and hydrophobic intraocular lens was implanted. The surgery was uneventful and patient was started on topical steroids and antibiotic. This is how the patient's eye looked at POD1 with minimal edema in the cornea, well formed and quite AC. At POD10, the visual acuity was 6 by 18. At POD13, patient suddenly complained of diminution of vision. Visual acuity was 6 by 36. Cornea was clear and AC was quiet. Dilated fundus examination was suggestive of macular edema, which was then confirmed via OCT, for which intravitreal triamcinolone was administered. At POD 38, there was further decline in vision to 6 by 60. Anterior chamber was peripherally shallow. There was formation of annular synecdoche, and IOP had raised to 24 millimeters of mercury. The patient was immediately started on anti-glaucoma medications. At POD 49, the visual acuity further declined to finger counting at 2 meters with microcystic edema in the cornea. The AC was shallow with iris bomb formation and IOP was 40 millimeters of mercury. Along with anti-glaucoma medications, the patient was started on IV mannitol and syrup glycerol, and the IOP was tried to manage conservatively. Despite the conservative management, IOP consistently remained above 28 millimeters of mercury. Therefore, NDAC peripheral iridotomy was done at POD 52. At POD 68, the visual acuity improved to 6 by 12. Cornea was clear, anterior chamber was normal depth and quiet, and IOP remained 10 millimeters of mercury. The cystoid macular edema had reduced with CMT being 120 microns. On subsequent follow-ups, IOP was maintained within 10 millimeters of mercury, with visual acuity continued to be 6 by 12. Patient was planned for left eye phacoemulsification with hydrophobic IOL implantation, but this time we, considering the complications in the previous eye, we did an intraoperative prophylactic peripheral iridotomy to prevent post-operative rise in IOP. At 4 months follow-up, the visual acuity in right eye was 6/12 and left eye was 6 by 9 parts. Anterior segment was within normal limits. IOP consistently remained in the normal range and fundus was within normal limits. Uveitic cataracts are typically complicated by presence of posterior synecdoche and poor pupillary dilatation, necessitating intraoperative pupil manipulation to achieve dilatation. These manipulations further exacerbate the post-operative inflammation, increasing the risk of cystoid macular edema, elevated IOP, and PCO. Intraoperative prophylactic peripheral iridectomy in our case reduced the risk of post-operative rise in IOP. And in conclusion, addressing the dual aspects of inflammation and cataract formation is the key to successful treatment. Perioperative steroid treatment is mandatory to reduce the chronic inflammation, as we all already know. Peripheral iridectomy can be considered because it proved to be beneficial in our case, and also hydrophobic lens was implanted to reduce the post-operative inflammation. These are my references. Thank you.
What was the time difference between the first eye and the second eye?
So it was about 3 months because there was a lot of complication going on in the first eye.
And after how much time, you took the first surgery of did you give any kind of the treatment pre-operative?
So patient was a diagnosed case of chronic uveitis and he was already on treatment.
Treatment of?
Topical steroids.
Only topical steroids?
Yes, sir.
So don't you give some kind of the oral steroid before you start the surgery for a few days?
So we are not practicing that.
It's a dictum. It's a thing that even otherwise a low dose steroid should be administered
Yes,
before
sir.
you take to the patient so that the eye is silent at the time of the surgery.
Surgery. Okay. Sir.
Thank you.
Thank you. Sir.
Next is Dr. Sameer Verma. Yeah. Vocal for local comparative study of Indian trifocal IOL and Indian EDOF IOL.
Good evening all. I started using this IOL about a couple of years back, and I was very impressed, and so I decided to do a prospective non-randomized study on it. It was a cataract follow-up study, and to assess the true nature of this IOL. So IOL as an effective tool, we know it provides multifocality, deals with spherical aberration and tackles chromatic aberration, and tries to minimize the effect of PCO, IOL decentration and pupil size. So these are the IOLs on which I did. This is the comfort, this is the EDOF IOL. This has got central 1.5 millimeter zone that provides the EDOF effect. And this was the multifocal, trifocal, hybrid trifocal that I did. And this was in those cases which had got more than 0.75 diopter of astigmatism. I used this toric lenses which has got a very nice lock haptic that helps in the proper centration of the lens. So study design was a prospective non-randomized study, single surgeon, single center study, bilateral, unilateral implantation of these IOLs. Primary outcome measures for visual acuity, defocus curve, contrast and adverse events were collected. Inclusion criteria was normal, like this. And I will skip some slide because I have got less time. And these were the exclusion criteria. So the uncorrected visual acuity, as you can see, distance visual acuity is very good. Out of 43 cases, 40 cases were 6.6, and out of 34 cases, 32 were 6.6. And then intermediate visual acuity with the EDOF lenses was quite good, because in more than 31 cases out of 43 cases, the vision was between N6 and N12 for intermediate also. And for near visual acuity, the vision was quite good with extend trifocals, but it was not that good with the comfort with the EDOF one. So the contrast sensitivity and dysphotopsia that I did at 1 month post-op, no appreciable difference in contrast sensitivity was appreciated. And then a questionnaire was used to assess the problem of dysphotopsia and night-time vision. 2 patients of extent with specific complaints of halos and glare was recorded, and night vision problem was recorded in 2 cases of extent. Basically, this lens, this extend lens has got all the multifocal lenses have got an algorithm of how they provide the diffractive rings, and this lens has got an algorithm that depends upon the Gaussian, super Gaussian curve that helps in softening the edges of the rings. That helps in decreasing the dysphotopsias. These are the defocus curve. These are the best and the worst of the comfort lens, and these are the best and the worst of the extend trifocals. And the spectacle independence with the extend trifocal was almost 90%. And for the attack comfort, you can see more than 35 cases have addition of, for near there was addition of only from 1 diopter to 1.5 diopter only. So the attack comfort, the thing is, it has got a 2.5 diameter zone, 2.5 diopter zone. In the 1.5 millimeter zone, there is a 2.5 diopter add is there, and it combines the progressive EDOF technology with monofocal for clear sharp focus for distance, excellent intermediate and functional near vision. This is there are 2 important things about this extend trifocals. That is the central refractive zone, that is clear of any diffractive rings, that is 1.2 millimeter zone, and that provides that deals with the challenges that are related to pupil size, tilt and decentration. The other thing about this lens is that is very important is the Gaussian profile of this lens. The the diffractive wings have got the Gaussian profile that is there in the blue, and it provides almost light transmission that is about 92%. That is because of this Gaussian profile that these trifocals provide very good distribution of light between intermediate, near and distance also. And since there are no sharp edges, the problem of dysphotopsias are also very much minimized. It gives equal distribution of light at near, intermediate and distance, and dynamic distribution of light in mesopic and photopic conditions. So continuous vision from 33 cm to distance and 3% of light transmission to retina, and MTF shows a wider zone of all three peaks, and energy loss significantly decreases with increase in pupil size. So the limitations of this study is about the pseudo accommodation that should be ruled out in all cases of multifocality. So pupillometry, spherical aberrations and higher order aberrations were not considered. So that doesn't deal with the pseudo accommodation that can add to the results. And the second thing is a more detailed study of contrast sensitivity with CSV 100E chart could have given better analysis. I did it Pele-Robson chart. The limitations, IOL decentrations and PCO rate were not considered in outcome measures. So the conclusions can be both of these IOLs are good options as presbyopia correcting IOLs post cataract surgery. Depending on patient profile and lifestyle, both of these IOLs can play a significant role. And the compromise on night vision and dysphotopsia of trifocals and EDOF IOLs can be revised with optical and biomaterial innovations. And a better study of presbyopia correcting IOLs should include pupillometry, wavefront measurements, and to give better analysis of outcomes. And last but not the least, if at all the cost is a factor, then this lens surely holds some promise. Thank you.
Thank you. How many patients were enrolled in your study?
This for the trifocals I used 43 cases, and for comfort the EDOF I used 43 cases, and for the trifocal I used for comfort I used 43 cases, the EDOF one, and for the trifocal I used 34 cases.
Right. Thank you. Next is Dr. Nancy Sharma. Dr. Nancy Sharma. Dr. Tanya Chaudhary next. Yeah, please. Emulsification surgery. Dr. Tanya Chaudhary, co-authors Dr. Renu Dashwana and Harsh Bahadur.
Good morning, respected judges, seniors and colleagues. I am Dr. Tanya Chaudhary, third year resident from Himalayan Institute of Medical Sciences, and I am presenting a case on a study of paired incision in phacoemulsification surgery. My guide is Professor Harsh Bahadur and co-guide is Professor Renu Dashwana. Now we all know that cataract surgery is the most commonly performed refractive surgery in the world, and astigmatism is a very common refractive error that we see in our day-to-day life. The prevalence of preoperative astigmatism is 86.6%, of which 35 to 40% have corneal astigmatism greater than 1 diopter and 19 to 22 have greater than 1.5. There are several options present to remove this corneal astigmatism or reduce it during cataract surgery, which can be limbal relaxing incision, incision made on a steeper axis, a paired incision made opposite to it, and a more expensive technique of using toric intraocular lenses. Thus, our study is basically focusing on evaluating the efficiency and complication of paired incision in controlling corneal astigmatism during phacoemulsification surgery in a cost-effective manner. My aim was to evaluate efficiency of paired incision in controlling the corneal astigmatism in phacoemulsification surgery and to assess the complication of these incisions. In a period of 12 months in our Himalayan Institute of Medical Sciences, an interventional study was performed in 56 eyes. Our inclusion criteria had 30 to 80 years of people included. Vertical and horizontal astigmatism was calculated, and it was in between 1 to 3 diopters. Exclusion criteria included that astigmatism should not be less than 1 or greater than 3. Oblique astigmatism, pre-existing corneal scar, keratoconus, previous ocular surgery, trauma, subluxated cataractus lens, or complicated cataract surgery were also excluded. Basically, all patients underwent detailed ophthalmic evaluation of visual acuity, diffraction, slit lamp examination of anterior and posterior segments, measurement of axial length, measurement of corneal curvature by manual keratometry. All patients that were included underwent phacoemulsification surgery. During the surgery, a primary incision was made on the steeper axis. And after completion of intraocular lens implantation, the anterior chamber was filled with viscoelastic and another incision was made right opposite to the primary incision. Now the keratometry difference was evaluated at 1 week, 1 month and 3 months after the surgery. This is a basic picture showing that the primary incision was given at 12 o'clock and a paired incision at 6 o'clock position, when the steeper axis was the vertical meridian. A total number of 56 eyes were taken, male were 25, female were 31, the mean age group was around 62.8 and majority of the patient lied between 61 and 70. Our preoperative vision evaluation was that 6x6 maximum number of individuals that were 16 had 6x60 vision. The preoperative refraction in the operated eye in the study population, here only the positive lens in the 90 or 180 degrees were taken and the spherical equivalence was excluded. So we can see that the maximum number of individuals, that is 33, 58.91%, was between 1.25 to 1.75 diopters. Now, since we have taken 1 to 3 diopter keratometry difference, we see that the majority of the cases were between 1 to 1.25, that was 46.4%. Now coming to 1 week post-surgery, we see that the vision improved till 6 by 9, that was in 32.1% of the individual. The refraction correction, the maximum number of individuals now had less than 1 diopter, that was 76.78%. The mean refractive correction was 0.77 plus minus 0.45 standard deviation, which was clinically and statistically significant comparing to the pre-operative evaluation. The keratometry difference, we can see the maximum number is between 1 to 1.25. Now we see that we took the 1 to 1.25 as a parameter, where 26 individuals were there pre-operatively, and now the individual, out of this 26, 12 had between 0.5 to 0.75 and 8 between 0 to 0.25. 6 patients remained the same. The mean was 0.76 plus minus 0.5, which was again statistically significant. We also found that the patient developed endophthalmitis but was managed thoroughly, attaining a vision of 6 by 12 by 3 weeks. That patient was also included in the study. Now vision assessment at 1 month, we can see there are maximum number of individuals had vision 6 by 6. Again, almost 85.71% of people had refractive correction less than 1 diopter. The mean difference when compared was significant statistically. The keratometry difference post-operative 1 month, again we can see the maximum number of individuals was between 0.5 to 0.75, that is 44.6%. The mean difference was again compared to the pre-operative evaluation, which was clinically significant. The vision again was 6 by 6 in maximum number of individuals, refraction less than 1 diopter, mean was statistically significant. And the keratometry difference, coming to the keratometry difference at 3 months, it was observed. Now the mean, again compared to the pre-operative evaluation, was statistically significant. Also, there were 56 patients taken pre-operatively having keratometry difference of 1 to 3 diopters, 30 out of which had less than 1 between 0 to 0.75 by week 1, 44 at month 1 and 45 by 3 months respectively. Also observed that 0 keratometry difference was seen in 7 individuals by week 1 and 10 by month 1. Conclusion: a simple paired incision applied opposite to the main incision on the steeper axis of the cornea in phacoemulsification surgery easily improves corneal astigmatism without any extra skill or instrumentation. A proper preoperative evaluation to estimate which one is the steeper axis in the cornea is important to determine where the incision, primary as well as a paired incision, should be made. In the era of only lenticular astigmatism, reduction in corneal astigmatism can also be achieved with the same instrument using a keratome in a cost-effective manner. Surgeons should also be aware of the risk and complication of a paired incision, thus not selecting patients with pre-existing corneal abnormalities, or should be aware of the wound leak, which can also, or if there is no
proper hydration. It can also lead to endophthalmitis. Take-home message is the paired incision on a steeper axis during phacoemulsification surgery is a simple, effective and cost-effective way of correcting corneal astigmatism. No extra instrumentation or skill is required, and the same keratome can be used as a cheap, safe and reliable method. These are the references, and thank you.
Which instrument were used for doing keratometry?
Sorry, sir?
For doing keratometry, which machine?
So a manual keratome was used, a manual keratometry machine that is used, that we use for K1 vertical keratometer and horizontal keratometry, when we assess whether it is between like 44 to 46, but which one is the steeper is our main aim.
And you said only single pair incision.
Yeah.
Suppose the keratometry difference was 1 diopter or keratometry difference was 3 diopter. So how you can correct with the same type of the incision?
So our pilot study was Dr. Uday Devgan sir, and it is said that by making incision, 1 to 2 diopters can still be corrected but not beyond 3 diopters. So my study included between 1 and 3, and the correction was taken whether it is less than 1.
Suppose the diopter difference is 3.
Yeah.
And diopter difference is 1. In one eye, one of the eye of the patient is 1, another is having 3. So how could you, was there any criteria for the depth, length or something
No,
else?
no such criteria. The same depth, same length, say 2.8 disposable keratome was used with all the patients. No differences were there in the patients having 1 diopter difference or 3 diopter
So
difference.
you think that the same incision will correct 3 diopters, same incision will correct 1 diopter?
The normal incision based, if we could talk about corneal astigmatism correction, if it is incision based, it will not correct the 3 diopter astigmatism as per the previous studies. My studies did not have individual till 3 diopters. It had maximum 2.25 and that was actually corrected till 1.
Right. Thank you.
Thank you so much.
Right, thank you. Thank you.
We thank everybody for your presentation, and we thank AIOS midterm conference for giving us this opportunity.
Second.